Welcome to this session in the International Conference on Social Determinants of Health. My name is Dr. Manoj Sharma. I am a professor and past founding chair of the Department of Social and Behavioral Health and an adjunct professor in the Department of Internal Medicine at the University of Nevada, Las Vegas, UNLV. The title of my presentation is The Applicability of the Fourth Generation Multi-Theory Model, MTM, of Health Behavior Change for Addressing Social Determinants of Health. So I will begin by sharing the evolution of clinical medicine, my parent discipline. So in clinical medicine, as you know, the first generation interventions were based on the signs and symptoms. And these were the clinical acumen-based interventions where the clinician was able to diagnose and treat various illnesses based on the signs and symptoms. Then came the second generation interventions, which were based on lab investigations like blood test, urine test, X-rays, and so on. And these were the investigation-based interventions. The third generation interventions, which are still going on, are the randomized control clinical trials, which are based on basis of which algorithms are derived and treatment is instituted. And these are the evidence-based interventions. And the fourth generation interventions, which are emerging, are based on genomics and technology. And these are leading to the precision interventions. So that has been the trend in clinical medicine. Similar trend has happened in the field of health promotion or interventions designed to address behavioral and social determinants of health. So first generation interventions were based on the KP surveys, knowledge, attitudes, and practices that led to knowledge-based interventions. These were present in the 50s and the 60s and it's still going on in some parts of the world. The second generation interventions emphasized skills like refusal skills, problem solving skills, cardiopulmonary resuscitation skills, and so on. These were the skill-based interventions. Third generation interventions were based on behavioral theories like health belief model, trans-theoretical model, so on. These were the theory-based interventions. These are still going on. Fourth generation interventions have are slowly replacing the third generation interventions. And these are based on multiple theories and use technology, leading to precise and brief interventions. So one such fourth generation intervention is the multi-theory model for health behavior change. It is about health behavior change as opposed to many of the earlier theories that were based on mere behavior acquisition. It is exclusive for health education and health promotion because it addresses both the cognitive, conative, volitional, and environmental factors. It has empirically tested constructs for health behavior change. It is parsimonious or has fewer constructs as opposed to many other theories which have multiple constructs which are difficult to reify. And its constructs are modifiable or changeable. It caters to both one-time and long-term behavior change. It is applicable across cultures. To date, more than 12 countries have implemented this particular model in various interventions. Precise and brief interventions can be designed, as I mentioned earlier. So let us look at what this model is through an animation.
Predicting, explaining, or implementing health behavior change is very complex. But a novel, fourth-generation multi-theory model of health behavior change developed by Manoj Sharma provides an effective solution. The model breaks down the health behavior change into two components: initiation or starting of the health behavior change, such as changing sedentary behavior to being physically active, and sustenance or maintenance of the health behavior change, such as performing regular physical activity. According to this model, for initiation or starting of a health behavior change, three things are necessary: participatory dialogue between the facilitator and client, which creates an understanding of the advantages and disadvantages of health behavior change; behavioral confidence, which can be acquired through multiple sources, such as self, powerful others, almighty, etc., and changes in the physical environment, which refers to availability, accessibility, and obtainability of the resources to make the health behavior change. For sustenance or maintenance of the health behavior change, also three things are necessary: emotional transformation, or converting feelings into goals; practice for change or active reflection about the health behavior change, and changes in the social environment with things such as support from family, friends, health professionals, and social media. The model is growing in popularity. It has inspired more than 100 publications and presentations using qualitative methods, cross-sectional, and experimental designs. And it is indispensable for designing precision interventions in health education and health promotion.
So this was a brief animation that showed what this theory is. Now let us watch a simplified explanation of this particular model.
Have you ever wondered why changing a health habit is just so hard? I mean, we all kind of know what we should do: eat better, move more, but actually making it a part of your life? That can feel downright impossible. Well, today we're going to dig into a really powerful model that might finally explain why that is, and more importantly, give us a real blueprint for building healthy habits that actually last. You know the feeling, right? That big burst of New Year's motivation that just fizzles out by February. It turns out this isn't just a personal failing. Nope, it's a super complex problem that researchers have been trying to solve for a long, long time. For more than 50 years, experts have been coming up with different theories, kind of like building toolkits, to try and explain how we change our behavior. But these early models, while they were a good start, had some pretty big flaws. So let's take a quick look at a couple of the most popular older models. It'll help us see why they weren't the complete answer. They were important for steps, for sure, but they just couldn't quite crack the code of lasting change. First up was the health belief model, or HBM. The basic idea was that we change our behavior based on how much we fear a threat and whether we think the benefits of changing outweigh the barriers. The problem? Well, it wasn't very good at actually predicting what people would do. It often ignored cultural differences, and frankly, it was better at explaining why someone wasn't doing something than actually helping them start doing it. Then came the trans-theoretical model, which you might know as the stages of change model. It sounded good on paper, but a lot of critics pointed out that its stages felt kind of made up and arbitrary. Plus, the model was just way too complicated for its own good. Researchers would say it wasn't parsimonious, and when they tested it, the results were pretty weak. So these models gave us some useful ideas, right? They were building blocks. But every single one of them was missing one fundamental, absolutely crucial insight about how change really works. And that, my friends, brings us to the multi-theory model, or MTM for short. This model was built from the ground up to fix the problems with the older theories and to give us a new framework designed specifically for health behavior. So, what is this game-changing insight? It's actually stunningly simple. Starting a new habit and keeping that new habit going are two completely different things. They are driven by totally different psychological factors. And the MTM is the first model to really build its entire foundation on that idea. Just think about it. The mental energy and motivation it takes to go for your very first run is not the same as the energy it takes to keep running 3 times a week for an entire year. Older theories just kind of mush those two things together, and that's a big reason why they weren't great at predicting long-term success. So the MTN breaks it all down into two simple phases. First, you have initiation. That's just getting started, taking that first step. Then you have sustenance. That's the long game, the process of making that new behavior stick around for good. All right, so let's dig into that first phase. What does it actually take to get started? Well, the MTM says there are 3 essential keys to unlock the initiation phase. The first key is something called participatory dialogue. Now, this isn't about someone lecturing you. It's a real, honest, two-way conversation, either with yourself or with someone else, where you genuinely weigh the pros and cons. It's about exploring the idea, not being told what to do. Key number 2 is behavioral confidence. This is a little different from a term you might have heard called self-efficacy. This is all about your belief that you can do this new thing in the future. And what's cool is that this confidence doesn't just have to come from you. It can be boosted by your partner, your doctor, or even your faith, which makes this idea work way better across different cultures. And the third key is purely practical. It's all about making changes in your physical environment. Basically, you want to make the right choice the easy choice. You're setting yourself up for success. So, keeping your running shoes right by the front door. It's about making things available and accessible. Okay, so you did it. You started. That is a massive win. But now comes the hard part, right? How do you keep going? Well, the MTM has 3 different keys for this sustenance phase. The first key to making it stick is emotional transformation. This means you have to actively get your feelings on board. You're consciously using your emotions, both the good and the bad ones, to power through that self-doubt and keep your eyes on the prize.
So that is the multi-theory model of health behavior change. And now let us look at the cross-sectional studies that have addressed social determinants of health. The first one that I want to bring to your notice is about colorectal cancer screening done in the United States, because there are disparities in that screening behavior. Another one is flossing behavior in rural Appalachian communities, once again, a very vulnerable population in the United States. Another group is pregnant and postpartum individuals with regard to physical activity behavior. And another study has been done in Kabul, Afghanistan, as you know, a troubled area with smoking cessation. Another one is in Fiji Islands to change physical activity behavior. Another one about COVID-19 vaccine acceptance in Hispanics and Latinx in Nevada. So these are all addressing social determinants of health. And then you can look at the qualitative studies that have been done, like with elderly patients and type 2 diabetes in China, pre-exposure prophylaxis uptake in people of color, quitting gambling among older adults. As you know, in the United States, the city where I live, Las Vegas, there are a lot of casinos, and a lot of older adults are hooked to gambling. So how to quit gambling, we designed this study. Another one is about COVID-19 vaccine willingness in China. Another one is about human papilloma virus vaccination in Ghana. Another one is about relapse to drug use. One is about water pipe smoking in Iran. So a bunch of studies have been done with regard to qualitative studies. And here are some experimental studies like exercise intervention in post-operative colorectal cancer patients, small portion size consumption behavior in an Indian context, reducing sugar consumption in Iran. Another one about tobacco cessation in Indian context. Another one about quality of life in Iranian post-menopausal women. Another one about water pipe smoking reduction, once again in Iran. So here is a case study, an experimental MTM-based intervention to initiate and sustain physical activity among a vulnerable group, which is the group of African American women. As you know, there is a lot of disparity in this group, like approximately 48% of the US population is not meeting the recommendations for a minimum of 30 minutes of moderate intensity physical activity for 5 days or 150 minutes per week. Whereas in African American women, only 35% meet those guidelines. So there is a big disparity there. So we designed a randomized controlled design, RCT educational trial, and this is the logic diagram. So at pretest, we measured the constructs of MTM, the 6 of those, the intention to initiate physical activity, intention to sustain physical activity behavior, total minutes of aerobic physical activity, anthropometric measures of BMI and waist circumference, and clinical measures of systolic and diastolic blood pressure. And the two interventions were the theory-based and the traditional knowledge-based intervention. And the same measures were done at post-test and 6 weeks of follow-up. So what we found was, this is the logic diagram of the intervention where how we reified the constructs. If you look, the participatory dialogue was reified by discussion of advantages and disadvantages. Behavioral confidence was built by demonstrations, practicing easy steps and giving tips. Changes in the physical environment by providing access to local gym facilities. Emotional transformation was facilitated by journaling, documenting experience. Practice for change was modified by giving and adjusting physical activity goals, and changes in the social environment was facilitated by the support system. So a challenging task was to engage this group of African American community of women. So we chose an African American educator, And there is a lot of mistrust in this community because of some big blunders that the public health has done, like the Tuskegee syphilis study and so on. So we were able to enroll. We had 74 women express their interest, and we were able to enroll 50 of those, and 48 completed the study. And several strategies were used, like volunteer participant observation, maintaining a blog website, giving text reminders, weekly phone calls, and additional makeup sessions. So process evaluation signified high degree of satisfaction, where 80% of the participants in the experimental group regarded the program as very good and excellent, and 100% said that they would be willing to participate in future. And with regard to process evaluation, the degree of fidelity was also very high. We had a structured tally sheets, observational tally sheets, and the program was delivered in the manner that it was designed. So here is the cell mean graph of the salient findings. If you look at the changes in minutes of physical activity, both groups began around 37 minutes of physical activity per week, which increased at post-test in the experimental group to 180 minutes and was sustained to 172 minutes. And the interaction was significant. As you know, the knowledge increased, but it was not at a practical significance level of 150 minutes. And it showed a partial eta squared of medium effect size. So conclusions and recommendations, we found that MTM is a promising fourth generation interventional approach. It can be reified in designing and evaluating for process and impact health behavior change interventions. It can be directed at high risk populations. It can be implemented in real world settings, and more refinement of instrumentation and interventions is needed. Another case study was also done with the vulnerable group of African American women. And here we focused on the fruit and vegetable consumption behavior, which is also a problematic behavior in this target population. So here is the consort flow diagram. We assessed for eligibility 136 women, randomly assigned 60 of them. In the experimental group, 26 completed, and the knowledge-based comparison group, 28 completed. And here is once again the logic diagram, the framework, the conceptual framework, the constructs of MTM, intention to initiate, intention to sustain, and number of fruits and vegetable consumed. And this time we had a follow-up of 8 weeks. So you can see once again the logic diagram of operationalization of the constructs. So for participatory dialogue, we had brainstorming, large group discussions, quiz, photo voice. For behavioral confidence, role play, photo voice, journal, cooking demonstrations. For changes in the physical environment, making the fruits and vegetables accessible and available, and showing cooking demonstrations. For emotional transformation, journaling, blogging, documenting experience. For practice for change setting and adjusting fruit and vegetable goals. For changes in the social environment, using family, friends, healthcare professional, and church support. And we utilized African American health educator, and here are some photographs from the actual session. And here are the results. As you can see, all the constructs were statistically significant, except for the participatory dialogue. And you can see here the fruit and vegetable consumption to begin with was about 2.77. Mean was 2.77. It increased to almost 5 at post-test, and at follow-up, it touched the 5 mark for the experimental group, whereas it was in the knowledge-based group, it was not at the practical significance level. And here is the cell mean graph showing that increase in the fruit and vegetable consumption, or the group time interaction, was significant. Once again, most variables showed statistical significance. We can design culturally tailored interventions, and replication of this study is realistic and feasible, and effectiveness trials can be undertaken. And here is an animation of cross-sectional research on MTM among disadvantaged groups.
The multi-theory model, or MTM, of health behavior change, understanding the determinants of breast cancer screening. Breast cancer is the most common form of cancer affecting women overall, but there are stark differences in breast cancer risk and survival rates between racial and ethnic groups. Breast cancers must be detected at an early stage to ensure timely treatment and the reduction of premature mortality. One important screening measure is mammography. In the United States, it is generally agreed women ages 45 to 54 should have a mammogram annually. Professor Manoj Sharma, a global health behavior expert from the School of Public Health at the University of Nevada, Las Vegas, UNLV, is working with colleagues to gain an in-depth understanding of the determinants of undertaking mammogram screening in typically underrepresented groups with a view to improving health through behavior change. The multi-theory model, or MTM, of health behavior change was developed by Professor Sharma in 2015. The MTM can be applied to a wide range of health-related behaviors. Two domains are core to the model: initiation of a specific health behavior and sustenance of this behavior. Professor Sharma has examined the utility of the MTM in explaining the determinants of mammogram screening in two underrepresented groups: Asian American and Hispanic American women. In each study, he used a cross-sectional methodology with a questionnaire to ask participants about their demographics and mammography history. Participants also completed specific items designed to test the theoretical constructs of the MTM, namely initiation and sustenance, as they relate to mammography screening. Findings from both studies confirm the utility of the MTM as an approach to understanding and modifying health behaviors. The findings also have important practical implications for the promotion of mammography screening. Professor Sharma discusses the utility of initiation constructs, such as participatory dialogue based on the assessment of advantages and disadvantages of getting a mammogram, behavioral confidence, or the extent to which an individual feels confident they will get a mammogram, and changes in the physical environment, such as improved logistical access, in supporting the decision to undergo mammography screening. In terms of sustenance, Professor Sharma discusses how emotional transformation, in which emotions are converted into intentions, is key, along with the constructs of practice for change and changes in the social environment. Professor Sharma's theory-driven research and recommendations have the potential to positively impact the early detection of breast cancer and subsequent survival rates in groups of women currently underserved in healthcare. The MTM also has the potential to be applied to a multitude of other health behaviors.
So that was about mammography. And now let us move to another challenging problem of breastfeeding in the United States. So let us see what this explanatory video has to offer.
All right, let's jump right in. We're going to talk about something that's super personal, but also a massive public health puzzle. And that is the huge, huge gap between how many mothers want to breastfeed and how many actually do long term. So, what's really going on here? So, check this out. A big national study recently looked at pregnant women in the US, and what they found was pretty incredible. A staggering 92% of them, almost everyone, intended to exclusively breastfeed their babies for the first 6 months. That's a huge number, right? But, and this is a big but, that's where the story starts to get complicated. Because when you put that intention up against reality, the picture changes dramatically. Just look at this. You've got that sky high 92% of moms who want to do it. But then you look at the actual data from the CDC for the 6-month mark, and it plummets to just about 25%. That is a massive drop. We're talking almost 70 percentage points vanishing into thin air. So the big question is, what on earth happens in those first 6 months? And look, this isn't just a simple case of people changing their minds. This gap is a real challenge for moms, for families, for the entire healthcare system. So researchers decided it was time to stop guessing and really dig into the science to figure out what's actually going on behind the scenes. To crack this case, a research team led by Sharma and his colleagues used a really specific scientific model to break it all down. They didn't just want to look at the surface. They wanted to understand the deep psychological and environmental factors that really predict who starts breastfeeding and, crucially, who is able to keep going. And the tool they used is called the multi-theory model, or MTM. Now, the genius of this model is that it doesn't treat breastfeeding like one big monolithic thing. Instead, it does something really smart. It splits the problem in two. It separates the challenge of starting from the completely different challenge of sticking with it long term. And you can see here how the model breaks it down. To start, it looks at things like your confidence, your physical environment, and whether you're weighing the pros and cons. But to continue, the focus shifts to stuff like your emotional drive, your practical skills, and the social support around you. So, okay, they've got this amazing framework. What did it actually tell them? All right, so let's tackle the first half of the puzzle, initiation. What is it that actually determines if a mother who intends to breastfeed actually gets started? And honestly, the answers were not what you might expect. So the data pointed to two things that were absolutely critical. First, what they call behavioral confidence, basically a mom's belief that she can actually do this. And second, the physical environment, having the right resources and support handy. But here's the real shocker. The one thing that didn't seem to matter, just knowing all the pros and cons. It turns out simply being told that breastfeeding is good for your baby isn't enough to get you over the starting line. The study also uncovered something really important about demographics. After crunching all the numbers, they found that Black women were significantly less likely to start breastfeeding than white women. And this really highlights that this isn't just about individual choice. There are bigger systemic things at play right from the very beginning. Okay, so that's what it takes to start. But what about sticking with it? What's the secret to being in that 25% who are still exclusively breastfeeding 6 months later? This is arguably the tougher part of the puzzle. Well, for this part, for sustaining, the answers were crystal clear. All three of those internal factors were huge. You needed that emotional transformation, which is all about turning doubt into clear goals. You needed practice for change, basically planning for problems before they happen. And you absolutely needed a strong social environment, support from your partner, family, and friends. But the model also flagged a massive roadblock. The number of hours worked each week had a major negative impact. It actively works against continuing. And this number is maybe the most incredible finding of the whole study. This model, just those few factors we talked about, could explain 59.1% of the difference between who kept going and who stopped. Now, to put that in perspective, in behavioral science, if your model can explain nearly 60% of why people do something this complex, that is huge. It's an incredibly powerful and useful result. So, what does this all mean for us? We've got the science, we've basically cracked the code. Why does it matter? Well, it matters because for the first time, we have a clear, evidence-based roadmap for how to actually help mothers succeed. And it really breaks down into a 3-part plan. First, for moms and families, the job is to build that confidence before the baby arrives and to make sure that social support system is rock solid. Second, for doctors, nurses, and lactation consultants, it's about moving past just handing out pamphlets. It's about using tools like goal setting and helping moms plan for roadblocks. And finally, for workplaces and all of us as a society, the message is unmistakable. Create policies and environments that make this possible, not an uphill battle. When you boil it all down, here's the truth this research gives us. That massive drop-off from 92% to 25%, it isn't a story about millions of individual mothers failing. It's a story about our systems failing mothers. The science is telling us the breakdown isn't in their desire or their intention. It's in the confidence and the support systems that we now know are absolutely essential. So here we are. The science has given us a clear roadmap. It tells us exactly where to put our time, our energy, and our resources to close that gap between what mothers want to do and what they're able to do. The question is no longer, what should we do? The question now is, are we actually ready to follow it?
So that was a video about the breastfeeding puzzle in the United States, in which systemic forces also play an important role. So now let us talk about the future directions where MTM can be applied in the context of social determinants of health. So better instrumentation, better interventions need to be developed through qualitative studies, more efficacy trials for different health behaviors, and social behaviors need to be developed developed, comparative cross-section studies with other theories need to be done, comparative experimental studies with other theories need to be done, the efficacy trials need to be scaled up for effectiveness trials, multicentric trials, and so on. And secondary data analysis from cross-sectional studies can be used to do profile analysis and so on. So those are the methodological future directions. Now let us look at the future directions in terms of behaviors. For reducing health disparities, we can design community-based interventions to address needs of underserved communities, like what we shared some of the case studies in this presentation. So more behaviors with more vulnerable target populations can be designed. For improving health literacy, patient-centered approach in clinical settings can be implemented. Strategies such as teach back, developing personal action plans can boost patients' confidence and empower them to better manage their health. Healthcare access and utilization for attending preventative care appointments, following understanding medication regimens, taking advantage of support services, etc. can be done. And then interventions in global settings, particularly in low and middle income countries, can be undertaken because of the low cost associated with this particular model. And then for mental and emotional well-being, stress management, like mindfulness, relaxation exercises, regular leisure activities, time management, other behaviors, interventions can be designed. For addressing burnout in high-stress professions such as healthcare, etc., interventions can be designed to set boundaries, taking breaks, engaging in self-care and other such related behaviors, promoting positive mental health beyond just treating illness, like gratitude journaling, building social connections, engaging in hobbies, developing resilience, for example, with the stress coping, emotional regulation. For substance use prevention and management, some work has been done, as you saw, with the smoking, vaping, etc., but more interventions for efficacy and effectiveness testing can be designed. Likewise, with youth and school-based interventions, also interventions can be designed. For environmental health and sustainability, like waste reduction and recycling, a big problem in countries, in high-income countries like the United States, behaviors like composting, reducing plastic consumption, interventions can be designed. Adopting eco-friendly habits such as lowering one's carbon footprint, switching to green energy, conserving water, using public transportation, those kind of interventions can be designed. Increasing outdoor nature contact, like hiking, gardening, walking in parks, those type of interventions and cross-sectional studies can be designed. For workplace and occupational health safety, promoting workplace wellness, wellness programs in corporate settings, physical activity during the day, better nutrition in office canteens, stress reduction techniques, those can be implemented. Injury prevention, adherence to safety protocols can be implemented. Financial health behaviors, this is a major problem in countries, high-income countries like the United States, where they take a lot of credit and end up with bankruptcy and such things. So developing balanced budget behavior, building confidence in financial decision making, saving for retirement, developing saving behavior as opposed to consuming beyond means behavior, receiving support from financial advisor or partner, those kind of interventions and cross-section studies can be designed. Then digital health interventions and telehealth. Digital therapeutics or DTX are evidence-based software programs that require prescriptions and are designed to treat medical conditions. So MTM can be used to design and address patient hesitancy towards using technology, especially among older adults and so on. Boosting telehealth engagement to increase patient engagement through telehealth appointments and so on. Implementation and evaluation of mobile apps. Implementation and evaluation of mHealth interventions can also be done through MTM. And personalized medicine and adherence, or the compliance behavior for multiple chronic conditions, it can be implemented for reducing opioid overutilization, a problem in countries like the United States where opioids are overutilized. So that can be reduced by application of MTM. Supporting cancer care, hospice care, those kind of care, FTM can be used. Supporting long-term treatment of infectious diseases in low and middle income countries, diseases like tuberculosis require long-term adherence. So those can be implemented. Long-term therapy of chronic diseases like depression, like diabetes mellitus, which require lifelong therapy, can be instituted. And then health information management and social media, combating health misinformation, managing information overload, judicious use of social media. Then interventions and cross-sectional studies for chronic pain management, non-pharmacological pain management, encouraging opioid stewardship. So those kind of studies can be undertaken. Climate change and environmental health, there's a lot of climate anxiety in people. So reducing that climate anxiety interventions can be implemented. Health equity and social determinants of health for food insecurity, housing instability, transportation access interventions can be designed. Pedagogical curricula development in public health and related fields can be done for developing syllabi and instruction of public health courses. So those are various applications. And here are some selected references of the studies that I used. And here is my contact information, manoj.sharma@unlv.edu. Thank you very much.